Um, Good afternoon. My name is Christopher Hartnick. I'm a professor of otolaryngology at the Massachusetts Eye and Ear Infirmary and Harvard Medical School. I'm going to talk today about Sturdor, Stridor, and babies that squeak and present a practical approach to caring for these children. At the conclusion of this course, participants should be able to adequately assess and characterize normal and abnormal pediatric airway sounds, understand current evaluation and diagnostic algorithms for children referred for abnormal airway sounds, and you are able to apply a practical approach to evaluating and treating children referred for noisy breathing. This lecture is designed for breadth and not for depth. Listen to this child. To understand this child, we need a framework to work within and to understand the story. We need to get some sense of where this sound comes from and what could be the problem and what clues can we use. When we ask ourselves where do the sounds come from, they could come from the nose, the oral cavity, the oropharynx, the hypopharynx, the supraglottis, working their way down to the subglottis, the trachea, and the lower airway. Well, these sounds can be divided into sturdor, stridor, and wheezing. Stridor can be differentiated into inspiratory and expiratory. Wheezing is really a sound that we hear lower in the airway. But if we understand these words, then we can understand a better sense of where the diagnoses may come from. So a quick review of the mechanical properties of airflow, being Poussin's law and then Bernoulli's law, will tell us that as airflow and resistance is affected, the airflow itself will produce a different characteristic sound, which we hear as non-laminar flow. What do these sounds actually sound like, and how can they help us? Let's start with the sound of sturdor, which is an inspiratory sound that sounds much like snoring, that really seems to emanate from the nasal cavity, the oral cavity, or the pharynx. This unhappy child can have a cold, can have a nasal obstruction, but really sounds stuffed or nasally obstructed. The sound of sturdor from nasal obstruction at night. Keep those sounds in your mind's eye or mind's ear, and let's listen to the sound of stridor, which can be both inspiratory or expiratory. Here we have a sound of inspiratory stridor, a musical sound coming not from the nose or the mouth, but perhaps just a little bit lower down in the airway. That sound that you can hear, there was difficulty breathing in, and then the slow breathing out. Change that to a biphasic stridor, breathing in and breathing out with difficulty. Listen to the seesaw pattern of the biphasic stridor, pointing to some area at the level of the vocal cords, which is where biphasic stridor comes from. Inspiratory stridor is the sound of an obstruction above the vocal cords. And one knows this because anytime there's a structure that's floppy, where the airflow hits it first, will be the course of the noise. If there's an obstruction above the vocal cords and a child breathes in, you'll hear inspiratory stridor. If there's an obstruction at the level of the vocal cords, you'll hear biphasic stridor. Below, you'll hear expiratory stridor. What I think it's important to know is that these sounds are localizers. When you actually see the children, look at them, look at where they're having trouble working to breathe. Look to see is the noise happening with inspiration and or exhalation. Use the clues you're given. Here we have some video. When you watch this child, See how the difficulty is on breathing in. There is an expiratory component as much, but this is a predominantly inspiratory stridor, characteristic of perhaps Laryngomalacia or some other disorder. As opposed to this child, who has stridor with breathing in and breathing out on inhalation and exhalation, characteristic of biphasic stridor, or perhaps bilateral vocal fold mobility or some other pathology. Wheezing is a distinct sound. The one hears with the stethoscope. It's lower on the chest, and if you listen to the acoustics of the sound, it sounds quite distinct from the sound of stridor. So where do we go from here? Well, we need a good ear and good eyes to look at the sights and the auditory cues. We'll watch the child and pay attention to these clues. So let's think, armed with a knowledge of what stridor, and wheezing are, what can cause stridor? Let's start at the top. Well, choanal atresia can cause stridor. It's an entity we've known for a long time, since the 18th century. There's a 2-to-1 female to male predominance. More often than not, it's unilateral. Embryologically, it's because of a failure of the buccal-nasal membrane to rupture, and its symptoms can really depend upon whether it is unilateral, where adolescents can present with unilateral rhinorrhea, as they've been able to breathe for years, but just have this obstruction or annoyance. Most children with bilateral choanal atresia present earlier on with frank airway obstruction. How do we diagnose choanal atresia? Well, by the inability to pass catheters through the nares into the oropharynx. Different textbooks say it can be an 8 catheter or a 6 catheter. I encourage you just to be sure that you can or cannot pass a catheter through the nares, and if you cannot, then have a suspicion for choanal atresia. The diagnosis is clinched by an axial CT at the level of the hard palate, and make sure you speak to your radiologist beforehand so they know the appropriate scan to get. The treatment of it really depends on whether it's unilateral or bilateral, and more importantly, what the symptoms are. The treatment also depends if these choanal atresia are a mix of bony and soft tissue involvement, which is the most common, or if they are a thick, bony choanal atresia, in which case a transpalatal form of surgery may be required. Here's an axial CT. The axial CT shows right here a choanal atresia. On this side, here we have the vomer and the pterygoid plate, and it's thickening. On the other side is what a normal choanal atresia looks like. This is what it looks like endoscopically when we look from the mouth and point up, where we can see here we have a patent choana and a choanal atresia, which there's no opening there from the nose to the mouth. Again, if we have a thin, bony choanal atresia with a soft tissue thickening, we can treat these nowadays endoscopically. Again, we look, and here's our patent choana and our choanal atresia. This is a unilateral. Looking up from the mouth up to the undersurface of the nose with the nasopharynx, and then placing an instrument through the nose, we can pierce this choanal atresia so we know directly where we are. We can use instruments to widen and then repair the choanal atresia. So in the end, we've got bilaterally patent choana. Other things can cause stridor, other narrowings of the nose, like piriform aperture stenosis, which is a bony outgrowth or overgrowth of the nasal process of the maxilla. The symptoms can be the same as with choanal atresia, but here you can't pass the catheters, but you can't pass them anteriorly. And the CT will show the difference between choanal atresia and piriform aperture stenosis. When we look at this scan here, we can see here is the nasal process of the maxilla, and it's marked narrowing right at the level here. Choana themselves are open. And if you see a central mega incisor, or 1, but not 2, top teeth, then your diagnosis is clinched. If these kids have failure to thrive, and if they can't breathe and eat at the same time, and they have labored breathing, we do think about repairing, which is a sublabial incision, such that we can see the undersurface of the nose or the maxilla and the piriform aperture from a sublabial incision or an incision underneath the top lip. We then can see the piriform aperture stenosis, and we use tiny drills to drill this piriform aperture out and to leave stents for several weeks while the wounds heal. Other things can cause stertor or nasal obstruction: encephaloceles, gliomas, dermoid cysts. If we look in the nose and we see any form of mass on one side and not both sides, we say to ourselves, watch out, be careful, get a CAT scan, get an image, and don't biopsy that before you know what it is. Here is a coronal CAT scan, and here we have the cribriform plate with a dehiscence of the cribriform plate on one side and a suggestion of a mass in the nose coming down from this, the intracranial component. An MRI would help distinguish this, but here is this bluish lesion with our septum and our turbinate, and this is the unilateral nasal obstruction that a child with stertor may present with, that we have to be careful of. And if we go back, we realize embryologically that there are some areas, both at the junction of the skull base and the frontal bones, called the foramen cecum, or the region between the skull and the nasal bone, called the fonticulus frontalis, and encephaloceles and or dermoids can appear from there, and we need imaging to be sure there is no intracranial connection before proceeding. Nasolacrimal duct obstruction can cause stertor or nasal obstruction. This is the most common lacrimal abnormality in infants, caused by incomplete canalization at the level of Hasner's valve. Most cases are mild, producing mainly ocular symptoms, but in cases that produce airway symptoms, can require endoscopic treatment consisting of marsupialization. And here's a child with a infected nasolacrimal duct cyst in the eye area. Here's the child who has a nasolacrimal duct cyst just below the inferior turbinates that are causing, as you can see, nasal obstruction and stertor. Endoscopically, here we find the septum, the inferior turbinate, and here is this nasolacrimal duct cyst that, using standard endoscopic sinus procedures, instruments, can be marsupialized and removed, and that's the end of that problem. But what about stridor? Let's continue. Let's start with inspiratory stridor. Remember, inspiratory stridor is caused by some form of soft tissue collapse above the level of the vocal cords. So what lives above the vocal cords? The most common cause of inspiratory stridor in a child is laryngomalacia. Laryngo for the area around the vocal cords, malacia for floppiness. Again, it sounds like inspiratory stridor. What it isn't is tracheomalacia, which is a floppiness of the trachea or the pipe below the vocal cords. As we discussed, sounds below the vocal cords will be expiratory. So tracheomalacia that's primary will have expiratory stridor. Laryngomalacia was classified in 1999 into type 1, type 2, and type 3. I don't find the classification into typing all that helpful, as much as I like to describe laryngomalacia into two broad character types, that of floppers and curlers, because they help me understand that if the severity is significant enough, what the treatment is that we would offer. Here we have our classic flopper, the right arytenoid or corniculate complex lopping into the airway with inspiration, causing airway obstruction. In my hands with this, I would treat this with the laser if the child were symptomatic enough. Here we have the classic curler. What we can't see is the vocal cords below. We're looking here at a patient suspended. What are we looking at? We're looking at the patient's epiglottis. We're looking at the arytenoids. So these bands right here are called the airy epiglottic folds, or the folds that connect the epiglottis to the arytenoids. When they're overly tight, it pulls the epiglottis in so you can't see the vocal cords. It's important to note that mild, moderate, and severe, at least in my experience, is not classified by the image that we see, but by the child's symptoms themselves. If the child is failure to thrive, can't gain weight, or is turning blue, or is working or laboring to breathe, then a supraglottoplasty or release of those structures is warranted. If not, then observation should be maintained, as most kids outgrow their laryngomalacia by somewhere in the age of 12 to 18 months. Again, when is laryngomalacia mild, moderate, or severe? It's corroborated by our laryngeal exam, but it's not solely based upon the laryngeal exam, but rather based on the clinical presentation. Is the infant child retracting, fatiguing? Are they working too hard to breathe so that they can't eat enough to gain weight? Growth curves are a pediatrician's best friend. Does the child ever turn blue? Other questions a parent may ask: how long will it last? When should I, the parent, be concerned? And are there any other studies to get, and when do we intervene? You must remember that 10 to 20% of children with laryngomalacia may have second airway issues. So if you can't explain the symptoms, or the symptoms are severe enough, you do need to look lower to be sure that is indeed what is going on. When do we intervene? Again, not on what the scope exam looks like alone, but on the clinical exam along with the fiber optic examination. Surgical intervention. Well, we intervene to treat the problem. We don't want to be a hero. The goal is not to take the noise fully away, but rather to diminish the work of breathing so that the children can breathe and can eat at the same time, and that when they are working to breathe, that they're not working to breathe so hard or depriving the body of oxygen such that there'll be long-term problems. A supraglottoplasty is done when the patient is suspended, sometimes with the endotracheal tube in place, sometimes with what's called spontaneous ventilation when the tube isn't in place, but you're able to see the airway. The long and the short of this is that close coordination and cooperation with your pediatric anesthetist is absolutely critical. If the patient has what we would call tight airy epiglottic folds, again, these bands connecting the arytenoids and the epiglottis, then these bands can be divided to release the airway and push it down below. Here we have a child who has these tight bands right here, and here's the pre-op and the post-op, and you can see that once these bands have been released, the arytenoids fall posteriorly, and the vocal cords, which could not be seen here, can be seen here as well. Well, it's important to note that not all inspiratory stridor is laryngomalacia, and that's the reason we scope these children if they have laryngomalacia. We may presume or assume laryngomalacia, but other things, notably juvenile recurrent respiratory papilloma, can also cause inspiratory stridor. And here we see a young child with marked papilloma of the supraglottis, who presents with some biphasic, but mostly inspiratory stridor. Look at this. This is something we absolutely have to know, because we can't tell that child to go home and solely to observe for the next 9 to 12 months until the laryngomalacia goes away. That would be a real mistake. Juvenile recurrent respiratory papilloma is predominantly from the HPV viral subtypes 6, 11, 16, and 18. 6 and 11 are by far and away the most common. The most important part about treatment of respiratory papilloma, number one, is to know that it's there, and number two, to pick the appropriate treatment option according to what technique is used at your institution and according to the site of the papilloma, such that you do no harm and don't injure the native vocal structures, which will allow the child to have improved voice over time. Well, what about biphasic stridor? Moving down from inspiratory to biphasic to the level of the vocal cords themselves. Well, vocal fold immobility, or we more common textbooks, vocal cord paralysis is the second most common laryngeal anomaly. I list vocal cord paralysis here because that's what you may see or read. But recognize that only with EMG can we truly diagnose a paralysis. And the common term is vocal fold immobility, which allows us to include both paralysis as well as paresis, as well as joint dysfunction that allows the vocal cord to have limited motion even if the nerve is intact. These forms of vocal fold immobility can stem from infection, from birth trauma, from neurologic issues such as the Arnold-Chiari malformation, surgical sequela with damage or ankylosis of the cricoretinoid joint, or a mass. 20% or more may be idiopathic, and it's very important when we see a child with vocal fold immobility to trace the course of the recurrent laryngeal nerve from the brainstem to the chest. The symptoms may vary according to if the child has unilateral or bilateral vocal fold immobility. Unilateral vocal fold immobility may be asymptomatic. The children may only have a weak cry, but they also may aspirate, and this is the key aspect of vocal fold immobility that's important to realize early on. Bilateral vocal fold immobility can be severe, requiring intubation and or a tracheotomy. And it's important to image these children, and both endoscopically as well as by radiologically when appropriate. What does vocal fold immobility look like? Look at the right vocal fold right here. The right vocal fold is mobile. The vocal fold is densely paretic or paralytic. In any event, it is immobile. One gets the sense that the vocal folds are not perfectly matched in the vertical dimension. Here is a child with bilateral vocal fold immobility. What you can't see is very much vocal fold motion at all. I don't know, is this a joint issue? Is there a mass in between the vocal cords, or do the nerves not work? It's very important to be able to video these lesions as patients are breathing quickly or children are crying. It's so important to be able to play it back over and over again, just so we know. Well, with regards to bilateral vocal fold immobility, the treatment is to protect the airway. If children really are having difficulty, they may require tracheostomy to allow their vocal folds time to regain function, many of which they do, depending upon the etiology. If they haven't had any resolution of their bilateral vocal fold immobility and symptoms for up to 12 years, for after 12 months, then there's a significant chance we may need to do something else in order to open the airway, either using a laser to open the back part of the vocal cord, or lateralizing the vocal cord, or placing a piece of rib cartilage or costal cartilage between the vocal cords to open these vocal cords up. Again, we would not do this before at least 1 year of age, and sometimes older, and the bigger the procedure, such as rib grafting, as opposed to a laser cordotomy, the greater the risk of postoperative aspiration, so we have to be careful. What about for unilateral vocal fold immobility? Well, many of these kids can compensate on their own, but some portion of them are either so hoarse or are aspirating so much that we need to do something. If we can think that our options can be either injecting a substance, putting a substance called thyroplasty, or more recently, the concept of laryngeal reinnervation has taken place. Here we see a Netter drawing of the cranial nerves of the neck. Here we see the cranial nerve 12, or the hypoglossal nerve, with the ansa cervicalis dropping off from the posterior aspect of the hypoglossal, traveling in relationship to the jugular vein, and coming around, looping posteriorly. If we use that nerve and we look at it anatomically, here we have a child's chin and their jaw. This is the digastric muscle. Underneath the digastric muscle, we can see the hypoglossal nerve. And here we see the ansa cervicalis, just like the drawing shows us, in close relationship to the internal jugular vein. If we looked at the strap muscle on the other side, so here again is our hypoglossal nerve, here is our ansa cervicalis coming down with our jugular vein. But on the other side of the strap muscle, where the thyroid has now been retracted and the trachea is medial, Here we can find the recurrent laryngeal nerve. And once we have found both, if we loop the ansa cervicalis after we detach it underneath the strap muscle, and then we can take the cut end of the ansa cervicalis and anastomosis into the cut end of the recurrent laryngeal nerve as it goes into the airway here, and we can develop a nice anastomosis here with the idea in mind not to have a child regain the motion of that vocal fold, but to have it medialize and position itself vertically such that the unaffected vocal cord can give good closure and the child can have a strong voice and not aspirate anymore. So if here's our child preoperatively with a feeding tube because the child is aspirating, the left vocal fold densely immobile. Here's the child 1 year after nerve reinnervation with excellent closure. And an excellent voice. It appears the vocal folds are oscillating or vibrating. There's no motion of that left vocal fold, but there's good, proper closure. And therefore, the patient no longer needs a feeding tube and has a good, strong voice. Well, what about expiratory stridor? Again, we're moving on down. Some of the first cases I'll show you may have predominantly expiratory stridor, but certainly for lesions just below the vocal cords, there is a cross between having still biphasic stridor and sole expiratory stridor. But in all of these, the expiratory stridor tends to be the most dominant. We can see subglottic hemangiomas, little growths that are benign but proliferative in the first year of life, that for some reason always develop just below and usually on the sides of the vocal folds themselves. In days gone by, the treatment for this was high-dose steroids for up to a year, as the proliferative phase of hemangiomas can be 9 to 12 months. The side effects of such long-term therapy was such that other surgical attempts were made, such as an open excision with removing the hemangiomas, such as using the laser to try to debulk this. Here's what a hemangioma looks like. Here's the right vocal fold and the left vocal fold, and you can see this child having almost near complete total obstruction of the airway just below, such that there's very mild stridor because there's not much airflow. And MRIs characterize the hemangiomas by a bright signal being taken up right next and just below the vocal cords themselves. Hemangiomas, again, can be removed surgically, but in one of the wonderful stories of medicine, propranolol has really taken over as a wonderful medical intervention that makes these hemangiomas, by and large, just vanish away, and children can be safely kept on propranolol for 12 to 18 months until the proliferative phase is over. It's very important if you use propranolol to speak to that child's pediatrician and be sure they don't use propranolol if they have the flu or any upper respiratory infection to the point that they're not eating, because if their sugar levels drop and then they take propranolol, they can seize. It's also important that these children have frequent checks at their pediatricians so that they can be weight-based adjusted. Probably the most common cause of expiratory dominant biphasic or expiratory alone biphasic stridor in children that I see is subglottic stenosis. This is an enormous topic. Subglottic stenosis can be congenital or acquired, and it can have various different forms of surgical intervention that I'll touch on briefly. This is the Meyer-Cotton classification of subglottic stenosis from a normal airway or grade 1 to a very tight airway where we can see here's the right vocal cord and the left vocal cord. Below there's just a pinhole of an airway to a child who has no airway. And this is a grade 4 subglottic stenosis. Subglottic stenosis develops just below the vocal cords where the red arrow would show. The grading system itself just talks about the two-dimensional axial narrowing. It doesn't say how narrow is the stenosis going up to the level of the vocal cords, or does it involve the vocal cords? It doesn't say how far down it goes. And these are really important questions to address before we start thinking of what surgery we should use to address this. For stenosis that's mild or thin, often congenital stenoses, we can approach these endoscopically. And there are different instruments now, such as this instrument called the vocal fold distractor. Here you see the distractor in place, splaying the right and the left vocal fold out to look properly at the subglottis. It's held in place by a very expensive rubber band, which one can get anywhere. This allows us to use two hands and to visualize the webs, the stenosis, what have you, in the airway in order to treat them. Here we have a child with a congenital subglottic stenosis in the form of a subglottal web. These are exactly what you would hope to see in a child with recurrent croup, as this is so readily treated. Again, the vocal cord distractors are distracting the right and the left vocal fold. The red that you see is a helium aiming beam, which allows us to aim our carbon dioxide laser in order to treat this. And we'll use radial incisions at 12, at 3, at 6, and at 9 o'clock to try to treat this web. Then, once we're done, we'll use a balloon to then fully dilate where we've used our laser. And in the end, we have a nice wide open airway if the stenosis is thin membered. If the stenosis is thicker, we may need to do open airway surgery in order to rebuild the airway and make it large. This can be in the form of either called a single, a double, or a 1.5 stage procedure, depending upon whether or not we take the trach out at the time of the first surgery, or whether we leave the neck stoma open, either a double or a 1.5 stage, until some later point where the child is fully awake, out of the ICU, and out of harm's way. In very general principles, here is a subglottic stenosis where we're looking down. The patient's feet are on the other side of this circle. Their head is facing where I am as I speak to you. These are the right and the left vocal cords, and in between there's no large hole, just a very narrow circumferential stenosis. This is post-operatively after a rib graft has been placed in the back, the front and the back, in order to augment this airway. How is this done? Imagine this is the cricoid cartilage just below the vocal cords themselves. We open the cricoid cartilage both in the front and the back, and we use a rib. We carve that from the right side of the chest to interpose it and distract it such that the airway becomes larger. In real time, the patient's chin is here, their neck is down here. This is their thyroid cartilage and their hyoid bone. When we open the airway and open the thyroid and cricoid cartilages like a book, what do we see? We see a narrowing in between. Look at this slit. This is the ventricle, or the junction between the right and the left true vocal fold and the right and the left false vocal cord. If you open this cleanly and correctly in the front, the vocal cords will stay nice and tight, and you can close them up very nicely. We then use a rib cartilage and carve it into the shape that we want with little flanges, so it will slip underneath the cricoid cartilage and not need to be sutured in place. We need to place this cartilage below the vocal cords so that we don't have aspiration afterwards. Here is the rib graft inserted just below the plates of the cricoid, but above the esophagus, so it sits nice and snugly and distracts the airway such that there's no residual stenosis. We then can place a graft in the front in the same time to further expand the airway. But what if the stenosis goes up to the level of the vocal cords? Remember, as we said, if it goes to the level of the vocal cords, that still would be a grade 3 or grade 4 if it was tight enough. But in that child, we would have to use a rib graft because we can't resect the area of the vocal cords. But if the scar is well enough below the vocal cords where we can carve out that scar and keep the vocal cords intact, this was called a cricotracheal resection. And our success rate in removing the tracheotomies with this form of incision of surgery is even higher. And in broad terms, if our scar is not at the level of the vocal cords, which might be halfway right down the thyroid cartilage, but is rather in the cricoid in the upper trachea, we can remove the front part of the cricoid. We can remove this, and we can drill down the back wall of the cricoid to make the whole airway thin. Once we've done that, we can lift the trachea up and bring it up into where this anterior cricoid has been removed. We bring it right on up so the trachea comes in contact with the thyroid cartilage. So this is truly a cricotracheal resection and a thyrotracheal anastomosis. Here we see the airway lifting up until we have the finalized thyrotracheal anastomosis and the scar has been fully excised. Moving down, more reasons of expiratory stridor. Again, the sounds localize the differential that there can be there. Expiratory stridor is not going to be laryngomalacia, and inspiratory stridor is not going to be tracheal stenosis, which presents with expiratory sounds. Much like subglottic stenosis, can either have a laryngotracheal resection or a cricotracheal resection. Tracheal stenosis can be treated depending upon whether it is a short segment of trachea, which can be excised and the trachea can be brought up and down to bring it together, or if it's a long segment tracheal stenosis where we have to do something other than resecting it because we won't be able to put the two pieces back together again. Here we have a child who had a motor vehicle accident and was intubated for a period of time with a very narrow midsection trachea. Well, what we do with that depends on how thick it is and how long the level of the stenosis is. If it's a very short segment, well, then we might resect with an end-to-end anastomosis by isolating the level of the tracheal stenosis, by resecting that area out, and by suturing the two areas of the upper and lower trachea back together again. If, on the other hand, the segment is too long, and when we look, it's more than, say, 3, 4, or 5 rings, then we can identify our trachea. On the top limb, we can make an incision on the back of the trachea, or at 12 o'clock, at 6 o'clock, let's say. Whereas on the inferior limb, we make our incision at 12 o'clock on the front limb. Then we slide the trachea, the top over the bottom, halving its length and doubling its diameter in order to allow us, in the end, to have a widened trachea and to take care of the tracheal stenosis. Expiratory stridor should then be relieved. This is the post-op view after a slide tracheoplasty. Well, we're almost there. We're working our way down to think of what other common things can we see that can cause us to have expiratory stridor. Tracheomalacia can do it, as well as vascular rings and slings. Again, tracheomalacia is not laryngomalacia. It's something that gives us expiratory, not inspiratory stridor. When we look at the trachea, much like the larynx can collapse with breathing, so can the trachea. When we look at the tracheal column here, we see it collapsing with exhalation, not with inhalation. It's very important to divide tracheomalacia into intrinsic or extrinsic. Intrinsic being either a deficiency in the cartilage of the anterior trachea or too much posterior tracheal membrane, so the trachea itself has not developed fully yet, as opposed to extrinsic, which is maybe a mediastinal mass, a tumor, or a vascular compression. Tracheal rings can cause expiratory stridor. And it's important to note when we look at the trachea, the normal trachea has C rings, or rings that stop perhaps here and here, where there's a posterior tracheal membrane in between. Here, as a birth defect, this child has congenital complete tracheal rings. Many of these kids will not need to get operated on, as they will grow with the child's life, as long as the children are only mildly symptomatic. For children that are quite symptomatic will either need a tracheal resection or a slide tracheoplasty, depending upon how long and severe the level of stenosis is. Finally, rings and slings. The most common anomaly of a vascular compression on the airway causing symptoms is the double aortic arch. It's important to note that because the most common anomaly we see is the aberrant right subclavian artery. And often when we see that, the children are just fine or aren't presenting with that as a symptom which needs repair. Here we're looking at sequentially at a child's airway. Here is their epiglottis. Again, their feet are on the other side of this picture. Here's their right and their left vocal cords. The food pipe is down here. Just below the vocal cords looks like a nice open airway. And here is the tracheal, posterior tracheal membrane. There's no complete ring here, as in the picture I showed you before. Look at the circular caliber of the upper trachea and contrast it to the lower trachea where the innominate artery is coming across, forming an ellipse just at the level, perhaps 2 or 3 rings above the carina. And once we get below that, here's the right and left main stem. So this is classic innominate artery compression. If the children are very symptomatic and are turning blue with feeds, there may be forms of PEXI procedures we can do, but that's only for children that are quite symptomatic. What about children who might have some difficulty breathing, some expiratory stridor, and perhaps some difficulty swallowing as well? Well, the right subclavian artery can come posterior to the esophagus and the trachea. And here we see a child's airway. Here's the trachea, and we see this indentation on the posterior aspect of the trachea. But when we look at an esophagoscopy as well, here's the esophagus. We know the esophagus is the tube below the trachea, and here we see a vascular pulsation on the posterior esophagus, pushing up into the esophagus, obstructing it, as well as obstructing the posterior aspect of the trachea. This may well be a retroesophageal subclavian or a right-sided subclavian artery in an aberrant position. And a CAT scan with contrast or an MRI is the way of identifying these various disorders. Finally, as we said, the most common symptomatic vascular ring or sling is that of the double aortic arch. And here we can see a CT that's been performed where all we're seeing is the aorta and the branching patterns of the arterial system to show a classic but beautiful demonstration of what a double aortic arch is. Here we'll see the double arch, the arch and the arch that comes around and squashes the trachea in between it. The treatment for this is to division of the non-dominant arch. So in conclusion, breathing issues in children, whether that be stertor, stridor, or wheezing, may not be as scary as it seems, although when we see a child who can't breathe, we have to think about our ABCs, to treat, and then to look for our clues. We need a methodical approach and use those clues. Is the sound we're seeing stertor, stridor, or wheezing? Is it happening when the child's breathing in on inspiration, breathing out on exhalation, or is it happening both in a biphasic pattern of inhalation and exhalation? Look at the patient for clues that will help you to do this. Use the sounds to construct your differential diagnosis that's according to where the site of this narrowing may well be. Once we've done this, we'll choose our imaging modality and our procedure in order to confirm an accurate diagnosis, and then develop a treatment plan. As you saw in the case of the child with the retroesophageal subclavian, often this is a team approach involving our pulmonary and our gastroenterology colleagues to accurately make a diagnosis and to understand what the treatment